I'm Linda Cheung. I work for Vaccinate PBM, which is all the VA hospitals in the state of Florida and San Juan, Puerto Rico. And prior to taking this position about 2 years ago, I was Jayla and Amanda for Tampa VA. So I continue to hold 1 or 2 half days of clinic here in ID clinic as well as GI clinic for the hepatitis C. So I've seen a couple of you, but so today I thought it would be a good idea for me to go over influenza because it's that time of year again, and there's been some updates since the ACIP American Committee on Immunization Practices guidelines that they met in October. So I thought it would be a good idea to just kind of give you an update on that. So just to start, okay, the Spanish flu of 1918, that was the most deadly influenza outbreak known to man. It was known to be caused by influenza A, H1N1, and thought to believed to be secondary to an avian flu from China, believe it or not. And I actually looked up because I said, where did I get the Spanish flu name? Because it actually affected 5 countries, Germany, Great Britain, and Spain was not one of the countries. But I guess back in those days, because there was no social media, they did not hear from Spain, so they thought that it was very deadly in Spain, and therefore, hence the name Spanish flu. There were 40 to 50 million deaths worldwide, 50 of them in young adults, 20 to 40 years old, and there were 500 deaths in the U.S. Subsequently, there's been about 3 pandemics. Some of you might have heard of these. Asian flu, 1957, also from influenza A. Hong Kong flu, 1968, again, influenza A. And then the avian influenza, 1997, again, influenza A. So there's a pattern here, right? A lot of influenza A causing many of these pandemics. Epidemiologically, the CDC estimates there's 25 to 50 million cases per seasonal influenza epidemic. About 114,000 of these patients actually get admitted to hospitals per year, and there's been about 36,000 deaths per year. We know that the high rate of infection in children, and then also those greater than 65 years old. And between 1976 to 2007, so about a 30-year interval, there's been anywhere between 3,000 to 49,000 people dying from influenza in the U.S. So influenza virus is a member of the Orthomyxoviridae family. There's actually 3 types, A, B, and C, but only type A and B cause disease in humans. We know it's highly transmissible respiratory illness. And with the influenza A, we know there's multiple subtypes, H1, H3, H5. There's even H7, H9, which is attributing to the yearly winter epidemics that we see. And then there's influenza B, which is more sporadic, and it's unpredictable when B comes and goes. Influenza affects, besides humans, birds, pigs, and horses, and we sort of have seen that over the years. Just to go over a couple of phenomenon with influenza, which is important, is the antigenic drift and the antigenic shift, right? The antigenic drift is a continual process. It's a point mutation or recombination in the viral genes, and that's why we have these yearly epidemics. It requires the vaccination yearly because once you're vaccinated, it does not recognize it for the following year. There's diminished immune response among previously infected or immunized persons to the drifted strains, and it can cause changes in susceptibility to the antivirals that are available. The antigenic shift, on the other hand, is very sporadic. It's unpredictable. And this involves a replacement of the hemagglutinin or the neuraminidase protein, causing there is no memory or there's no immunity within even the population. And this causes the pandemics, some of the unpredictable pandemics. So this is flu activity since about 2 weeks ago. This is available through the CDC website. And as ID fellows, it might not be a bad idea for you to sort of check this sporadically to see how much flu activity there is. Is there a pointer on this? Maybe not. Okay. So here's where we are. We're about week 45 in 2016, and this is just an enlargement of this section over about a 6-month period. And if you look at this, it's very comparable to what was happening last fall around this time. So the red is H3 activity. The green is more B activity. Okay, so the peak of the season will be here probably in the next couple of months. And we peaked probably around week 10 of 2016. So very similar in activity in as far as respect to A versus B and the amount. If you look at it by age group so far through the 12th of November, as you can see, the majority of it, it's been H3N2 activity. And the purple is greater than 64. And that's sort of what we're, because we don't see pediatrics, so H3N2 and the elderly is quite a bit of activity, and then 25 to 64 is sort of runner up there. This is the activity across the U.S. through week 45. So there's a couple of pockets where there's quite a bit of regional activity. Puerto Rico, for those of you who may be traveling for the holidays. Make sure you're vaccinated if you're going to Puerto Rico. And then you've got New Hampshire up in the northeast, and then I don't know why Oklahoma just sort of right dead in the center. There's been some local activity as well as Oregon. But other than that, it's just mainly been sporadic activity. So when we look at testing methodologies, there's actually, 5 or 6 different ways you can diagnose influenza. And I'm just going to concentrate on the 3 that we use most frequently. And these are the 3 that are done here at the VA. So the first one is, and I guess before I go on, just wanted to highlight, so all 3 methodologies test for A and B. Only these 2 are CLIA waived. So this one is actually a send out. Okay? So keep in mind, turnaround times are going to be much quicker because we do them here in our lab. Whereas this, we have to send out. So you're looking at days before you'll get the result on that. And I'm going to go through each one and when you would use it. So the rapid antigen test is very simple. It's easy to perform. You probably will get your results in 30 to 60 minutes. These, what we call flocked swabs, are available in your clinic. So in ID clinic, if you have a patient who comes in and you're suspecting influenza, you can get the nurse to swab them right there and then. You don't need to go run and get a tube from the refrigerator or anything like that. It's a nasopharyngeal swab, or it's a nasal swab because they provide the highest yields. They will not run it on throat or washings because the yield is very low, so it's going to be inaccurate on this test. So you can do it at the clinic as a point of contact. It's useful for detecting outbreaks in clinical management. It screens both A and B. But the catch is it does not screen for subtypes. Okay, so your result when it comes back, it's going to say influenza A or influenza B. You're not going to know if it's a H3 or H1. Okay? And the catch is it's very specific. This test is very specific. Upwards of 95% in children, maybe a little less so in adults. But the caveat is it's not a very sensitive test. Right? We know that. So at the beginning of the season, like now, and also at the end of the season, where the prevalence is low, you're going to see a lot of false positives when it's truly negative. Okay? Which means you might need to run a confirmatory test on these. Height season, in that section where there's a lot of activity, where the prevalence is high, you're going to get a lot of false negatives. Okay? Again, when it's truly positive, your test may show it that it's negative. So the thing to keep in mind is ideally you want to collect your samples within 3 days, and that will heighten the accuracy of the result. The other two tests that are available is the rapid molecular assay, which I'm sure all of you are familiar with, is the viral respiratory panel, right? So when you get an RVP, it actually provides you with a panel of different influenza viruses, as well as adenovirus, RSV, parainfluenza virus, and it also lists for you if it's an H1 or H3, but it does not list for you H5, H7, H9 on that panel that we do here. Again, it's a nasopharyngeal swab, and you usually get the results within 3 to 5 days because they have to process it. Even though the test is rather quickly to run, it does take a couple of days to run. And it does need to go in an M4 media. So if you use the flock swab in clinic, it's not going to work for this. You cannot send it for RVP. It has to go in an M4 media, which is kept in the refrigerator. So if your nurse does not have it in their refrigerator down in clinic, someone has to go to the lab and get one, because otherwise you're not going to get an RVP. The other test we run here is the PCR. This is the most sensitive test. However, the turnaround time is a little delayed. And again, it does take the nasopharyngeal swab, and it only identifies H1N1. So you're not going to know if it's H3, which we're seeing the most activity right now, right? So just kind of keep that in mind. Again, this requires a special media, so it does use a UTM media, again, kept in the refrigerator, okay? The other thing is if you need... I spoke with Dr. Augusti about this. If you need a send out because you're looking specifically for a particular, if you have a suspicion, patient's been traveling and, it could be H7 or H9, then they can send it, and Dr. Augusti will have to process that for a send out. Okay, the other laboratory tests, the immunofluorescence and the serologies, are not done much anymore because of its limitations. The immunofluorescence, it's more sensitive than the point of contact tests. However, it does require skilled personnel to run the test, so they don't do that anymore. As well as the serology testing. The serology testing takes weeks to come back, and usually your patient is gone by then. And basically you take convalescent titers the first week and then 2 to 4 weeks after to see if their titers are going up or down. So those two tests are no longer done. So the three that I mentioned are the primary ones. So before we start talking about the drug, let's sort of look at the neuraminidase and the influenza, the life cycle of the influenza virus. So on the upper part, panel A, you have the host cell. The virus invades the host cell. It releases RNA, right? And then it infects the cell. Then it branches off. On these little posts here, you have receptors that contain salicylic acid, and then you have neuraminidase, which are antibodies that protect the virus, and these enzymes that come along to help cleave the salicylic acid so that the virion can bud off and then go off and infect other host cells, right? So what the neuraminidase inhibitors, or the drugs that we're going to treat these patients with, is they actually inhibit this reaction. So by sticking onto the ends of these, it does not allow the enzyme to come off and cleave them from this post. Okay, so they can't go off to infect other host cells. So the neuraminidase inhibitors have been shown to reduce the duration of influenza symptoms by about 1 to 1.5 days. When it's administered within 2 days of the illness, it does reduce lower respiratory tract complications, pneumonias, and hospitalizations if it is done in a timely fashion. However, beyond 48 hours, it offers little to no benefit. And the effectiveness for H5 is really unknown. Safety, also the safety in pregnancy or nursing mothers is also unknown. So they're not the best drugs for the treatment of influenza. There's actually 3 drugs on the market to treat influenza. or for chemoprophylaxis. The first is also Tamiflu or Tamiflu. Second is Zanamivir, Relenza, and then the third one is Peramivir or Rapivab. All three of them cover A and B. The treatment doses and chemoprophylaxis doses are there for you. Basically, the dose is cut in half for chemoprophylaxis. So instead of BID, you would give it daily for chemoprophylaxis. And then duration is a little bit different. So treatment is 5 days, and chemoprophylaxis is for 7 days. The one thing I wanted to highlight, actually two things I wanted to highlight, is Relenza, the one that's inhaled, should not be used in individuals with COPD, asthma, or actually if a patient is in the unit, if they're intubated, it's going to be hard to administer Relenza. Okay, so that's a precaution there. And then also Peramivir, it's an IV formulation. We actually had a patient who we needed to get compassionate use before it came on the market, and I think we might have used once or twice even after that. I'm not sure.
We were supposed to do that second study when I was at the PI meeting, and that's when we had the pandemic, the H1N1. And so declared a pandemic, which meant that opened it up to emergency use, and we can't count that data during the study, so it killed the study for us.
So this is only available as an IV formulation. It's a one-time dose, 600 milligrams. You give it over 15 to 30 minutes as a one-time dose, and it's not indicated for chemoprophylaxis. Okay, so the only time you would use this if you have a patient who needs antiviral treatment, who you're questioning their absorption of this drug, right? Or if they're in the unit and you can't give this and they can't swallow pills, this is probably the only time you would use this drug. The other thing I would like to point out is the studies that looked at A and B activity, they were predominantly A in those studies. There were very few Bs, influenza Bs in these trials with the Peramivir.
On the Tamiflu, you said if they're in the unit, they can opt to use the Peramivir if they can't swallow. You can't crush it and give it.
It's a capsule. Yeah. It does come in liquid, though. Okay. It comes in liquid.
So, but still, it can be an option if we're able to.
Yeah, but if you're questioning absorption issues in patients.
You can get a compassionate use from Glaxo.
Which? This? Zanamivir? IV? Oh, okay. Compassionate use. I didn't know that. Okay. They don't want me to know that. All right. Okay, and then these are some recommendations for renal adjustments in patients who have end-stage renal disease on hemodialysis or even peritoneal dialysis. Basically, you cut the dose in half with each of these, and it does come in a 30 milligram capsule. So you can cut the dose at the 60 cutoff, you cut that dose in half, and then further reduce it by daily dosing. And if they're on hemodialysis, you dose the 30 milligrams after every hemodialysis cycle. So if they're on Monday, Wednesday, Friday, they only get 3 a week, 3 doses. And then peritoneal dialysis, it's 30 milligrams times 1 immediately after a dialysis exchange. And these are the recommendations for chemoprophylaxis. Essentially the same sort of pattern, but you start with Q-day here because this is the treatment regimen. And then these are the recommendations for the IV formulation if you have to use that. And for the Relenza, it's not recommended for end-stage renal. Okay, so the best treatments are still the vaccinations, right? Because we know our therapies aren't that good. So I wanted to spend some time to talk about the new ACIP recommendations and then some of the vaccines that are available. So for this year, there are 2 A's, H1N1, H3N2, and then a B, which is the Victoria lineage. So the vaccines, if you've already gotten your vaccines, this is what you got. If you got a quadrivalent vaccine, you got the additional B strain, which is the Yamagata lineage. And I'm going to talk a little bit about that. So 2A and 1B is what everybody got if you got the trivalent. If you got the quadrivalent, you got 2A's and 2B's. So it used to be real simple, right? You go up and say, I want a flu vaccine, and there was only one to choose. But now there's, 5 or 6? And then within each category or type, there's even several by different manufacturers. So there's 4 different trivalents. You've got the inactivated, which is the very traditional one that we've been used to. You have a cell culture base now. You have a recombinant formulation for those who have a true egg allergy or allergy to the inactivated vaccine and cannot take the inactivated vaccine. You've got an inactivated but a high-dose vaccine. You've got an inactivated quadrivalent vaccine. And then we still have the live attenuated inhaled, although for this season now, it's no longer recommended. So we should not be using this anymore. Okay, so if someone has needle phobia, this is no longer recommended even. And I think mainly because of the inactivity of it from last year. So you think that's confusing? This is what we have to choose from now. So you send your patient go get a flu shot, and you don't tell them which one. Who knows what they got, right? Did they get a quad? Did they get a high dose? Did they get a tri? So I'm going to start at the bottom and sort of work my way up. On the bottom, we have the flu mist, which is the nasal, which is no longer recommended. So that's easy, right? That's basically, we don't do that anymore. The flu block is the recombinant product. So these are your patients who are truly allergic to egg, cannot use the inactivated. Very, very few. And actually, the CDC updated their egg allergy algorithm, which I'm going to share with you a little bit later, and strengthened their language in your assessment of that egg allergy. So there's going to be very, very few. I think North Florida, South Georgia, which is the Gainesville VA, they ordered a box of 5 last year. I think they didn't use any of them. So, there's not going to be. We haven't. Tampa has not traditionally ordered any. Fluzone is your high-dose vaccine, and then I'm going to go and talk about each of these categories. Okay, so quadrivalent versus trivalent. So again, quadrivalent, 2 A's, 2 B's, trivalent, 2 A's, 1 B. Okay, so looking at the immunogenicity and the efficacy, they're similar in immunogenicity and efficacy between the quadrivalent and trivalent for the shared strains. However, obviously, it has improved, the quadrivalent has improved immunogenicity and efficacy over the tri for the mismatch B, right? So if someone got influenza B from Yamagata, because you gave them the trivalent, so obviously if they got infected with influenza Yamagata B strain, well, yeah, it's probably not going to offer too much protection. Although there is some data that it does offer some cross coverage. The outcomes and the effectiveness, there's really no outcomes data comparing quad versus tri. And then if you look at quality of life modeling and cost data, there were some studies looking at U.S. and Canadian, assuming that there's 0% cross activity or just between the 2 Bs, the Victorian and the Yamagata, that it would take about 10 years. You would have to use it for 10 years to garner a cost savings. Here for the VA contract price, a trivalent flu shot is about $6, and the quad is double that. So it's about $12, $13. So in summary, based on several of the trials I've looked at, I think it offers very modest benefit. It really is dependent on your B strain concordance. So years that CDC has been able to identify the predominant B strain, those are going to be probably good years, and you probably may not need the quadrivalents. But for those years that maybe they didn't figure out which is the more predominant B strain, then it may offer some benefit. ACIP for 2016-17 did not offer any preference of the 4 over the 3. Now let's talk about in elderly patients, so high dose versus standard dose. On the left, we know that as we age, we have declining humoral and cellular immunity, which results in a reduced immunologic response to vaccines, right? The magnitude and the quality and the persistence of the antibody also declines. So I know this is a little bit small on the left, but I think it shows you what I wanted to share. And that is, in the dark, it's the unadjusted, which is the younger age group, 18 through 59. And the white is the adjusted, which is greater than 60. So as you can see in each of these graphs, seroconversion as well as seroprotection, the elderly are lower than the younger age group. So high-dose vaccine is basically standard dose vaccine, but 4 times the antigen. So for each high-dose vaccine, you're giving them 4 times the amount of the standard dose, 60 micrograms of antigen per strain. And with the standard dose, you're only offering 15 micrograms of the antigen strain at 4 times the cost, too. So the amount of antibody produced with the high dose is obviously going to be higher because you're giving them 4 times more antigen. The proportion of persons successfully immunized and protected supposedly is also higher with the high dose. However, the amount of injection site reactions with the high dose is a little bit higher than the standard dose. Although if you look at 7 days out after the injection, there's the lines sort of merge. So high dose is a little bit higher early, standard dose not so much, but if at 7 days they probably about the same. So again, a little small, but I think you get the gist of this. High dose is in the dark blue and standard dose in the light blue. So in each of these cases, this is all subjects. This is looking at hemagglutinin inhibition, and this is neuraminidase inhibition, or neutralizing antibodies. In each of these cases, the dark is a little bit higher because you're giving them more of the antigen, right? There's actually outcomes data now with high dose and standard dose. So several years ago when we were looking at high dose, there wasn't, but now there is. So the first 2 trials were published by Diaz-Granados, and the first trial he published was in 2013 at a vaccine looking at 2009-2010 season. And if you look at the results, by PCR confirmed influenza-like illness in the high dose, there were 2.29% versus standard dose 2.962%. Not statistically significant between the two. In the New England Journal, and this is quoted all the time, he actually extended that to 2 seasons, to 2011 through 2013, about 30,000 patients. This is a well-conducted trial, lots of patients, and it was prospective. Okay, randomized clinical trial prospective. However, a couple of criticisms of this trial. Half the authors of this paper worked for Sanofi, and also all patients with moderate to severe acute illnesses were excluded. So all of your sicker patients were excluded. So probably all of our VA patients would be excluded from this trial. They had to have lab-confirmed influenza at least 14 days after they were vaccinated. And the results, look at here, 1.4% with high dose and 1.9% with standard dose. So it did a little bit better, right, than standard dose. But more importantly, we would need to treat 220 patients with the high dose to avoid 1 case of laboratory-confirmed influenza over a 2-year period. Okay, so at 4 times the cost. Subsequently, there's been 2 other trials. These 2 are not prospective. These 2 are retrospective. The first was at a Lancet ID, and they looked at CMS data. Okay, so tons of data. High dose, 1.6 million patients got the high dose versus 900, almost a million, got the standard dose. They looked at primary outcomes, which is a probable influenza illness, and then inpatient admission or ED visits. And the results was the high dose, 1.01, standard dose, 1.3. Okay, and this is events per 10,000 person weeks. So again, a little, what's the significance? No one really knows. And then the last trial is, again, a retrospective trial. And this is out of the group in Philadelphia. And they looked at a VA cohort. There were 23 VA medical centers across the country. 25,000 of them got high dose. 139,000 got standard dose. They looked at hospitalization for pneumonia or influenza. No difference. high dose and standard dose. However, there was a trend towards some benefit in the high dose when they further stratified them by age groups. So if they're greater than 85, they seem to have offered some benefit, whereas if they were 65 to 75, not so much. And then hospitalization for all cause, again, not much difference here. It was not statistically significant. So in summary, I think the high dose is more immunogenic. It perhaps offers slightly higher efficacy, particularly those in 85 years and older. At least that's what it's trending towards. We do not have enough evidence that translate into meaningful improvement in patient-centered outcomes. We just don't have enough data to support that. And it's marginally cost-effective, but we're not really clear. Again, ACIP last month has given high-dose influenza vaccine a neutral recommendation. So they do not strongly recommend it.
Is that an oxymoron? Neutral recommendation?
It's safe.
It's a recommendation neutral. I don't know. I'm sorry.
So that's sort of where the expert's opinion is on that. Okay, so the new kid on the block is Fluad. It's not really a new kid, but new to the U.S., relatively new to the U.S. Fluad, it's an adjuvanted trivalent inactivated vaccine, thus the abbreviation small a, TIV, which we'll start seeing in the literature. It's made by Securus. I can never say it because there's not a U after the Q, which, that would be a... it was first approved over 20 years ago in Italy, so it's been used a long time, a lot of data there. And it's available in 38 countries, including the Canada, but it just got approved in the U.S. last year, about a year ago. It is a trivalent standard dose. It is an egg-based vaccine. And it is approved for individuals greater than or equal to 65 years of age. It is formulated with an adjuvant, and it's called MF58, which is an oil and emulsion squalene oil derived from sharks. So they extract the oil from sharks, put it into the vaccine. And you can buy like squalene shark liver oil over the counter and things like that. So basically, by adding the oil to this vaccine, it enhances the immune response for patients who receive it. It reduces the amount of virus needed for the production of the vaccine, and it also allows for greater supplies of the vaccines to the manufacturer. So the blue is the adjuvanted TIV, and the red is the traditional TIV. So as you can see, if you look at the GMR, the seroconversion, and the seroprotection, with the adjuvanted vaccine, it's higher. And GMR is geometric mean ratio, so basically the measurement of the reactivity of the vaccine. Oops, wrong way. Okay, so this is the influenza vaccine in persons who report egg allergies. Again, updated from years prior. And the language is just a little bit stronger now with the egg allergy. So when patients say they have an egg allergy and they can't get the vaccine, you're supposed to ask them, after eating eggs or egg-containing foods such as cake, do you get hives? And if all they get is hives, then it's still okay for them to receive the inactivated vaccine. Okay. However, if they get hives, but in addition they get cardiovascular changes, respiratory distress, wheezing, reaction requiring epinephrine, these very severe reactions, then the ACIP is recommending that you consider the recombinant vaccine. Okay. So just a little bit stronger language compared to years past. So in summary, I think we just need to stay up to date with the activity in our area and nationally. So check FluView CDC often during the influenza season. Review up-to-date guidance based on emerging surveillance data, antiviral recommendations. There was one year oseltamivir wasn't working. And I think everybody panicked and wanted their flu shot then. So I think that's what needs to happen again for people to get their flu shots, because we're not doing so well this year again. Look for local trends, and then improve communication strategies to your patients and other providers. Use local surveillance data, clinical judgment, and appropriate diagnostic tests to guide your treatment. And I only saw a picture of Obama. I don't know if Trump gets vaccinated. I couldn't find a picture of him. And then obviously wash your hands, because, as you're touching doorknobs and elevator buttons and things like that. And that is all I had.